All right. Well, good evening, everyone. I'm Julie Creech-Organ, and welcome to tonight's edition of the National Fellows Online Lecture Series. This evening, we are going to learn about exertional leg pain from Dr. Nathaniel Nye. Before we get started, I wanted to introduce our upcoming lecture, which is scheduled for the 13th of September, same time, 8:30 p.m. Eastern Time. We're going to have Dr. Dan Herman talk about transient neuropraxias. Couple of ground rules for this evening's presentation. Like the other ones, the goal of our presentation is to help serve as an adjunct to your program's individual education opportunities, as well as get you connected and get you kind of some interactive experiences with some of our expert AMSSM members and at other times, some of our invited guests. And then, of course, also to assist in our CAQ preparation. We ask that throughout tonight's presentation that you mute your microphone and turn off your video. If you have questions as they come up through the presentation, please feel free to submit those into the chat. I'll be monitoring for those, and then we'll have a question and answer period with Dr. Nye at the end. And then we do ask that you stick around for the end of the program. There'll be two different surveys that we'll submit through the chat. One where you can just tell us how we're doing and provide us an evaluation so we can continue to make our presentations better. And then a second where you can actually suggest topics and speakers for upcoming lectures. So without further ado, I want to introduce our speaker this evening, Dr. Nathaniel Nye. Dr. Nye is a sports medicine physician who just this summer began a new position at Intermountain Health in beautiful southern Utah. He recently separated from the Air Force after 13 years of active duty service. During this time, he served as the Assistant Program Director at the National Capital Consortium Sports Medicine Fellowship, which is located at Fort Belvoir Community Hospital in Virginia. While there, he trained 8 military and 7 civilian fellows per year, while also teaching over 60 rotating residents and medical students per year. He is an associate professor of family medicine at the Uniformed Services University of Health Sciences, which is located in Bethesda, Maryland. Prior to getting to Fort Belvoir, he served 5 years as a sports medicine physician, supporting the Air Force's basic military training. While he was there, he diagnosed and treated thousands of bone stress injuries and published his research on bone stress injury. He also developed from the ground up a sports medicine network consisting of 35 sports medicine professionals working in 10 embedded sports medicine clinics supporting basic military training enterprise. He and his team demonstrated a large positive fiscal impact via a 3-year 980,000 grant funded study, which has since been published. And hot off the presses is some new data that he just finished compiling for a bone stress injury study, which is really interesting. They looked at prospective serial MRIs, lab data, including vitamin D and iron, as well as assessment of gait and some kind of sleep and nutrition, all of those different studies, and looked at how all of those factors correlated with symptomatic bone stress injuries. And I won't give away the punchline because he might tell us about it later, at least, or you guys can read the study, but I will go ahead and turn it over to Dr. Nye.
Awesome. Well, thank you so much, Julie. I am going to go ahead and share my screen if I can execute that correctly. It is a pleasure to be on here. I really appreciate the invitation, and let's see. Can you see my slides now?
Yes.
Great. All right. Well, thank you again, Julie, for the invitation. I'm very happy to be on here and have this opportunity. And thank you to everyone who's dialed in and sharing your evening with me and with us, as well as those who are listening virtually after the fact. So before I dive in, that photo on the right is me and my daughter and my dad hiking the Virgin River Narrows in Zion National Park. It is so awesome. And I'm loving being just literally minutes away from that. So very cool. All right, I have nothing to disclose, and these viewpoints are my own. I do not represent anyone else in giving this lecture. Tonight's learning objectives, we're going to go over basic terminology related to exertional leg pain. We will go over the broad differential diagnosis for leg pain, and we will go over the presenting signs and symptoms of some of the primary causes of exertional leg pain, as well as the keys to managing these etiologies. So, some terminology to get out of the way. Tonight, we are talking about exertional leg pain. That means pain between the knee and the ankle. That can be any cause. It could be nerve, tendon, bone, or honestly, a long list of things. We'll go over that, but the key is that it must be worsened by exertion and relieved with rest, and that is what defines exertional leg pain, and that's what we'll be covering. Um, the term shin splints is something that we try to avoid, or at least understand its context. It is a layman's term. It is not a proper diagnosis. All it really means is leg pain. And it doesn't imply any particular etiology. I will comment that I have seen radiologists, and good radiologists, using this term, shin splints, as they read a bone scan. And sometimes they will comment that if there's diffuse mild uptake along the tibial diaphysis, they will oftentimes call that shin splints. But keep in mind that that is not a diagnosis, and we are trying to one up our game in terms of how do we use this in the clinic and what is shin splints. Really, it's more of a term that the athletes are going to use. Okay, differential diagnosis, and I tip my hat to Peter Bruckner. This is his article from 2000 in MSSE, a great differential diagnosis. We're going to spend most of the lecture going over the things that are on the left-hand column in the common list, as well as popliteal artery entrapment. But I want to make sure that I've put in front of you the things that are not to be missed. We have to always remember that we are doctors, and not everything fits in to the same pattern every time. So we need to keep in mind for tumors and malignancies, we need to keep in mind vascular etiologies such as peripheral vascular disease, peripheral arterial disease, venous insufficiency, or even things, the next few on this list fall more into the endocrine category, with primary or secondary hyperparathyroidism, which can result in rickets in children or osteomalacia in adults, Paget's disease of bone, often seen in older people over age 60, and so forth. Wish we had time to go over everything. I'm going to add just a few things to this list for your consideration. A lot of times we might see exertional rhabdomyolysis in people who have exertional leg pain. Very different, kind of a unique presentation there. There's some unique factors. We won't go into it, but just cruising down the list, a chronic exertional compartment syndrome can, in very rare cases, convert to an acute compartment syndrome. Exertional sickling should not be forgotten. Your athlete may or may not have sickle cell trait. You should be aware of their sickle cell trait status and consider whether that might actually be sickling related symptoms. And on down the list, there can be nerve entrapments, arterial endofibrosis, and importantly, remember the spine. Lumbosacral radiculopathies often present as unilateral radiating pain. Lumbar spinal stenosis probably would present bilaterally. Okay. And on to the big four with a nod to the recent conference realignment theme. These are our big four. I will be using these acronyms throughout the talk. Bone stress injury, BSI. We'll talk about tenoperiosteum/fascia injury, which is medial tibial stress syndrome, MTSS. We'll go over muscular etiologies, including CEX, chronic exertional compartment syndrome, CECS. Vascular etiology that we'll talk about is popliteal artery entrapment syndrome. All right. Now, the rest of this talk will mostly be case-oriented, and here's our case number one. 17-year-old female, high school senior. She's coming to you complaining of 2 weeks of bilateral exertional leg pain. So you start to get into the weeds a little bit and ask her a little bit more detailed questions. She says, well, the pain worsens, starts to get, a little bit worse in the first 10 to 15 minutes, but as she keeps running, it just gets really painful and unbearable. She says they're painful to the touch after she runs. This is her first year on the track team. She's not been a runner in the past, mostly sedentary. Her friends invited her to join the team, and she was decided to give it a try, and no prior running injuries. So you get onto your examination and you notice that she's got a non-antalgic gait. She walks in and sits down. On palpation, you notice that there is diffuse, mild to moderate tenderness along both medial tibial borders, nearly the entire length, and it's symmetric both sides. Range of motion and strength are both symmetric and unimpaired. You ask her to do a single leg hop on both sides, and she's able to do that with no problem. And a set of x-rays, a tib fib series was normal, and you've looked at the images and you've confirmed that you agree that they are indeed normal. Now, what do you make of this case? What do you do? Obviously, this is based on your differential diagnosis. And do you need advanced imaging? Do you need to go so far as to pull her off the team and put her on crutches and so forth? Well, so your differential, if you're thinking at the top of your differential is MTSS, I would agree with you. This is a novice athlete with some risk factors. And she has a history and exam that are consistent. This is a relatively recent onset of symptoms, diffuse tenderness and pain. And we should always be considering the possibility of a bone stress injury. Reassuring in her case is that she's only had 2 weeks of symptoms. So it would be difficult to develop a pretty severe bone stress injury within a relatively short amount of time. It would be helpful to know, and I didn't tell you, how long has she been training and actually running and ramping up her volume. That would be an important detail for you to gather. Her hop test was negative. That is reassuring. And she had a negative x-ray. So what is MTSS? That is a great question. And the truth is, nobody really has a definitive answer on what it is. Many people regard it as a traction periostitis. And this is from Dr. Bruckner's article. And I believe that, in my experience, most clinicians today kind of treat MTSS as if it is this etiology, like a traction issue, a periostitis with the soleus and posterior tibialis tugging on the periosteum and just creating tension, maybe some inflammation. So alternatively, others have proposed that it might be a soleus bridge issue. What is the soleus bridge? Well, the picture to the right depicts this. This is actually straight out of an article from 1985 in AJSM. And to this day, it remains, I think, quite credible theory on MTSS. That there is this fascial connection, and there really is, between the soleus and the tibia, the medial border in particular, and that is the soleus bridge. And as you can see, when the foot and ankle pronate, there is a greater degree of strain on that soleus bridge, and that makes perfect sense because we know that pronation, a greater degree of pronation, is associated with MTSS. Now, MTSS may in some cases actually be a precursor to bone stress injury. And the reality is, a lot of these people will show up in clinic, they've got mild diffuse pain, they restrict their activities, they get better, they never had an MRI, and no one can ever actually confirm. But the truth, I think, is that probably there's some elements of all of these in most of our cases that show up as what we call MTSS. And maybe someday in the future, we'll be able to better delineate what is exactly going on. But this is our current understanding today. Risk factors for MTSS include, as I mentioned, pronation. Now, it's hard to measure pronation in clinic. One thing you can do, though, is measure navicular drop. And you do that by having them stand with their foot on the ground, but bearing weight on their other foot. So their foot in question is just resting on the ground. Mark the navicular by palpation, and then have them put measure the height to that mark, and then have them put all their weight on that foot, and then measure how high is your mark on the skin over the navicular. How high is it now, and what is the difference? That's your navicular drop. Individuals with MTSS have been found to have a navicular drop on average between 6 and 8 millimeters. Non-injured athletes tend to be in the 3 to 5 range. And this has been found to be consistent between 3 systematic reviews with meta-analysis. This is a consistent finding. These meta-analyses also found that increased hip external rotation with the hip in a flexed position is a consistent risk factor for MTSS also. So I would encourage you in your clinical exam to look at hip external rotation with a hip at 90, and that is correlated. And in another talk, we can talk about why. But female sex, increased BMI over 30, sedentary lifestyle, low VO2 max are also associated with MTSS. So in general, you should think of this as mostly an injury of relatively novice athletes and runners. Okay, so moving on. This is a clinical diagnosis. There is no test you can order to confirm that that is what it is. The diagnosis hangs on a good H&P and normal x-rays. Often you'll see a constellation of risk factors and diffuse tenderness on exam. But always, when you're considering this, you need to consider your clinical judgment. How concerned are you about a possible underlying BSI? What would be the possible adverse outcomes if you miss a significant BSI or another etiology? So you just need to put your doctor hat on, and that's how we earn our paycheck. Treating this involves reducing running mileage and intensity and or improving running form, because this is a tissue load tolerance issue. And if you can reduce their loading by improving their running form, a lot of times that involves changing them out of an overstride heel strike pattern, usually with a slow cadence. That's how they come to you, novice athletes typically, and you train them into a higher cadence, shorter stride, reduce their overstride heel strikes. You're getting to a midfoot strike typically. And if they have a narrow foot placement, or almost like running on a tightrope, you would want to widen their foot placement so that there's a little bit of more space in between, and that helps reduce the degree of pronation that is required and the eccentric loading on the posterior tibialis. Okay, rehab. These guys need to strengthen their core, strengthen their feet, and work on those glutes. This I would recommend that you do either guided with a good home exercise program or work with a good physical therapist. Okay, moving forward into case number 2. We've got a 24-year-old male cross-country runner. He's an experienced runner. He's a senior. He's never had issues with leg pain in the past. Now he's coming in saying he's got right greater than left leg pain with running for the past 4 weeks, is what he'll admit to. He says it slowly gets worse. He has to stop so bad that he has to stop. He limps after finishing his workouts for the last few days. He's been increasing his mileage, trying to set a PR, trying to get to regionals. It's his last year in college cross country, and no significant running injury history, except for some mild ITBS. Okay, so on exam, he does have diffuse tenderness to palpation along both tibias, but you notice it becomes focally severe tenderness at the mid shaft of the tibia, and it's on the right, which is the leg that hurts worse. And you ask him to do a single leg hop test, and he does all 10 hops with no pain on the left, but on the right he stops after only 3 hops with pain. And you get some x-rays, they look normal. You review them, you look closely, they look normal to you, you don't see anything. Now what do you do? Okay, so if at the top of your differential you have bone stress injury, I agree with you. This is screaming bone stress injury. So you get an MRI. Well, that's a really good question. You don't have to, actually. I think most of us would. I probably would. And the questions that I'm asking are, can this patient pay for it? Are we in a resource limited setting? Sometimes in the military, you can't even get an MRI for another month or two. Unless you call the radiologist and label it as a stat study. Or do you need expedited decision making? A lot of times with an athlete who's on a team, you need to kind of get an answer sooner than later. And so a lot of times athletes will end up getting an MRI, so that you can plan your rehab and try to project how long are they going to be out to the best of your ability. You don't have to, and we'll talk about that more. You can just do serial X-rays if you're suspecting a low risk injury, such as a tibia. Do you restrict this guy from running? That's, I think, hopefully a clear yes, because he is limping off the track after he finishes his workouts, and he's had worsening pain, severe tenderness. I had this guy. Do you put him on crutches? Well, again, this is a judgment call. In my hands, I would probably put this guy on crutches at least until I follow him up after he gets his MRI or at least another X-ray. See him in a couple of weeks or sooner, and see how he's doing. But I would set his expectation that he's probably going to need to be on crutches for up to 4, maybe even a little bit longer weeks. And it's just going to be a kind of a game day decision, how we may need to extend or could even, best case scenario, shorten it. Let's talk a little bit about bone physiology. Bones are alive. They live and they adapt all the time to the loading that they experience. There are 2 cell types you probably know. Osteoclasts do the bony resorption. Osteoblasts do the bony deposition, the osteoid matrix. And these 2 cells communicate with each other. They live in a harmonious balance, the yin and the yang. They need each other. They work together to make sure that the bone is optimally structured and that the tissue can withstand the loads that it's under. However, there is the bony resorption phase typically outpaces the bone formation for about 2 weeks. So that's why a lot of times after someone changes their activity level, it takes about 2 weeks or more to start feeling the bone stress injury symptom. This is a spectrum of injury. There's no moment when it becomes a bone stress injury. There's shades of gray, all the way from an unstressed bone to a normal stress response. And at some point in the middle, it becomes a pathologic stress reaction. It can come all the way to a non-displaced or even a fully displaced fractured bone. And I like to point out on this slide that all the way to the right is obviously unhealthy. All the way to the left is also unhealthy. A bone that is completely unstressed is going to eventually become osteopenic, and we don't want that either. So normal bone needs to be under stress, some degree. This needs to be really consistent and not rapidly changing. You should know BSI risk factors. I'm not going to go over all of these. I've put stars by a few key ones. Number 1 would be the rapid change in physical activity. It's the volume. It could be walking, marching, running stairs, and really just about anything else that loads the bones. Done in a high enough volume can cause a BSI. Vitamin D deficiency, very common, and that is a risk factor. Low BMI, under 18.5, would be a risk factor as well. And we want to start thinking about energy availability in these athletes, males and females, and help them address those caloric needs. History of BSI is a strong risk factor, and that comes out in all the studies that look at BSI risk factors. I would also point out, often overlooked, iron deficiency is a risk factor. Don't forget menstrual history. Don't forget medications that can lead to bony resorption. In particular, Depo-Provera I found is common that young athletes will use, and they don't know that it can reduce their bone density. Location is key. You should know this for your boards. Look at that high-risk list on the left. Femoral necks, we're talking knee to ankle today. So anterior cortex tibia is in that category. It is a high-risk injury. Glance at the rest of this list, but this is something you should know. Talus, navicular are considered high risk. Tension and compression sided. Now, tension sided bone stress injury is higher risk than a compression sided injury. So in the case of the tibia on the right, a tension sided tibial bone stress injury is high risk. They really are prone to overt completed fracture. or non-union or poor healing. They can take a long time. This is the dreaded black line. Notice the X-ray on the left that is most noticeable. Right at the mid-diaphysis of the anterior portion of the tibia, you've got that defect, that lucency, and that is the dreaded black line. If you see that, you should call your orthopedic surgeon. This patient should not bear weight. They should be on crutches, and they will likely need a rod all the way down the marrow cavity of their tibia. PSI history often consists of a gradual onset of pain. It worsens with exertion. It's usually atraumatic. Sometimes the patient will kind of twist their ankle or something and feel like that is why it hurts. But all they did was kind of unmask the symptoms of an underlying BSI. So don't be fooled by that. Usually 2 to 6 weeks after a change, mild to moderate swelling may be present, often with some night pain. Dig deeper. When you find these people, you got to ask them more questions. Find out what are the factors what are all the straws that broke the camel's back, and that's your homework to do with the patient, is fix those. On exam, they may limp. That should make your stomach. That should raise your alert that this is a higher degree, a more serious bone stress injury. On exam, they should have bony tenderness if it is a bone that is palpable. Keep in mind, between the knee and the ankle, the fibular diaphysis is not directly palpable. Fibular midshaft stress fractures often they present a lot like a muscle strain or a muscular cramping. It can seem like it's muscle. I've been fooled more than once, so keep that on your radar. Really quickly, tuning fork test, I feel like, is common. I don't think it's any better than actual tenderness to palpation, and I've actually collected data on that, and it does not bear out that the tuning fork has any predictive value, so I don't recommend it. But I want you to be aware of it because some people do it. The fulcrum test is only validated for the femur, the femoral diaphysis. So I've seen people do it for the tibia. That is not, I don't recommend it. It looks like you're trying to snap a log over your knee, and it just doesn't feel right. It's not sensitive or specific. I do not recommend using that test except for the femur. And a single leg hop is a great way to gauge progress with this issue. So an athlete may come in and you can test them, and then, well, they could only do 3 hops, and next time they come in for follow-up, they may get kind of disheartened with feeling like they're not making progress, but you can show them, hey, look, today you did 10 hops, no problem. That's progress, and that helps the athlete. It's a good check before you start putting them on a treadmill too. Make sure they can hop without pain. All right. In basic military training, we did some work on this, and we actually developed an algorithm and published it, and then we gathered some data on 778 trainees who presented with lower extremity pain, and we assessed them for 18 clinical variables that can be considered risk factors. And we did some fancy stats, logistic regression, and developed this model. And lo and behold, we tried to develop a clinical prediction tool like a scoring system. Lo and behold, that scoring tool could do no better than simply just assessing for bony tenderness to palpation. So that's the real take home from that study. Bony tenderness alone has a strong negative predictive value for bone stress injury in and below the knee. Most of these bones are palpable. The exception is the fibular diaphysis. If you are suspecting a low risk bone stress injury, which most of them are below the knee, except for a few exceptions, the navicular talus, if you can manage that just with serial x-rays, in particular, if they have all the clinical signs, and if they have no bony tenderness, you can defer imaging, but you should use your judgment and make that decision. Here is the algorithm that we optimized. I would love to walk you through this with some detail, but bottom line, this starts with an athlete presenting with leg pain, and you assess for bony tenderness. So we're in the top center. If they have bony tenderness, we're starting to move towards managing and diagnosis of this. So we're going to get x-rays right away, every time. You're going to restrict their running, limit their total impact. You may need to give crutches if their walking is painful, or if you suspect a high risk or a high grade stress injury. Consider getting some basic labs, 25 hydroxy vitamin D, a CBC, and an iron panel. That's what we do in basic military training. Those deficiencies are common. We stop NSAIDs if they're on them. I don't give them NSAIDs to help with their pain. Maybe Tylenol, but usually nothing for pain. And I consider starting them on a vitamin D supplement, but I'd avoid calcium supplements until I've ruled out an iron deficiency, because that is very common too. Calcium competes with iron for absorption. Once you have imaging that shows a bone stress injury, you're done. You've got a diagnosis and you move forward. At their follow-up, if their x-ray was negative, I follow them up. And I may get another x-ray and or an MRI at that point, if imaging thus far has been negative. And then we move on to management. Before I talk management, I want to give you some stuff on imaging. The best evidence for initial imaging, this is wide consensus on this, and ACR appropriateness criteria. X-ray is your initial imaging in all cases, unless you consider a bedside ultrasound, and that would be great. You know, we're sports docs, by all means use the ultrasound, but get an X-ray if you ever suspect a BSI. It's low cost, minimal radiation, few false positives, high specificity. You get it right when they see it. When it's on there, you have very high specificity, but it does lag behind their clinical presentation to see any findings on the X-ray. So on the right, I have thrown up a couple of X-rays. The one on the top is a tibia, and if you look closely, there is a faint periosteal reaction. That is what a periosteal reaction looks like if you haven't seen one. This one is early. The lower image is a more mature periosteal reaction that's been there for a while. This is callus formation, but it does fall within the category of a periosteal reaction. You'll see radiologists describe it that way. But this one on the bottom has been there probably for a couple months, if not longer. Okay, advanced imaging. If you need advanced imaging, MRI is the clear-cut first choice, not bone scan. It has equal sensitivity, greater specificity. It gives you much better anatomic localization of the injury. You can grade the severity much better. It is not a truth machine. There's still some judgment that goes into this, and sometimes it can be hard if it's a mild, if there's just a faint periosteal reaction, it can be hard to pick it up, even on a good MRI. On the right, look at, there's an axial stir. I want you to see what a BSI looks like on an MRI. So here we've got white, black, white. If we start at the marrow cavity of the tibia, notice that there's this white flare adjacent to the bony cortex, and then you see the bony cortex, and then outside of the bone, the periosteum is whitish as well. So it's like an inverse Oreo. A healthy bone has a gray marrow cavity and a gray periosteum. So here we have a coronal stir sequence on the bottom left. This is a very fluid sensitive sequence, so bright, light up really bright. It's very sensitive for BSI, and coronal T1 here for comparison. Bone scan gives you a wide field of view. It's a very large anatomic area. There is radiation exposure with this. It's similar, comparable dose to a CT abdomen pelvis. This takes a long time. It's 3 to 4 hours. It's non-specific. Anything with bone turnover will light up. So anatomic detail. I do not recommend bone scans very often. It's very seldom that I will get one, but when I would consider a bone scan is if I'm suspecting multiple bone stress injuries scattered on distant locations that would be that would require multiple MRIs. I may just go with the bone scan. Treating BSI hinges on getting to the culprit. Usually the biggest one is improper load management, too much, too soon, too fast. So that's the biggest thing. We've got to re-educate the patient. Gait analysis and gait retraining are critical. That's another talk in and of itself, but if you don't fix the mechanics that contributed to the injury, they are likely to wind up right back in your office with a similar or the same injury. Kinetic chain abnormalities, muscle restrictions, tightness, weakness, or simply a muscle that's not timed well or active enough. So those need work and those take time. And I recommend either a good home exercise program with your guidance or refer to physical therapy or a good athletic trainer. So don't forget metabolic status. Don't forget female athlete triad, and that the male athlete triad also is relevant, although we don't get menstrual, obviously, any changes in that regard. So a metabolic workup is something that you may have heard about. That is another topic for another day. Treatment of bone stress injury, I think of in two stages. Stage one is like putting out the fire. You got to put out the fire before you think of anything else. Stage two is rebuilding the house. And it takes, depending on how much of the house burnt down, you may have more work to do. Putting out the fire is all the restricting stuff. It's crutches, it's taking them off the team, or pulling them off the playing field or the track, and takes a different amount of time. In this table in the bottom center, you can see I've given approximate time frames for a low risk and low grade bone stress injury with no fracture line, and for a high risk and or a higher grade injury. So high risk means the location. The high grade refers to how severe, how extensive is the damage at that location. And so some of these injuries can take a very long time, months, and I've seen them take just a couple of weeks. If you catch it early, it's a mild, low risk injury. If you really catch it early and restrict them appropriately, retrain them, they can actually heal quite quickly. So there's a wide range, and this takes a lot of clinical judgment and good follow-up. Plan ahead, set good expectations up front. I've given you a pretty typical progression here of weight bearing and resuming running. So a lot of times we have them non-weight bearing for some period of time. The first step is from there is to get them walking again, full weight bearing with simple ADLs. Word of the wise, I oftentimes use a pedometer, recommend a pedometer on the patient at this stage so that they can know where they're at and modulate, that they know if they get over 6,000 or 7,000 steps, they're going to start getting sore. And they need to test out what is their limit, and they need to stay below that. So a pedometer can be helpful. Cycling is nice and low impact. Elliptical training is usually beyond that because it's full body weight on the foot. Treadmill comes later. Anti-gravity treadmills are nice, but I think it's for the 90 and 9 not necessary. Aquatherapy is again nice, but for most people not necessary. So more on that another day. Jumping into another case. Now I have a lot of things to say about these upcoming topics, so I'm going to need to go a little quicker here. This is a 34-year-old male firefighter with progressive left greater than right leg pain. He says it slowly starts hurting. Around mile 1, it starts to really set in. And man, about 2 miles in, he gets really bad pain, pressure. He gets some numb and tingling in his feet. He even starts, if he keeps going, he starts to get some foot slapping on the ground. If you've seen this type of presentation before, you know exactly where I'm going with this case. He's got no prior running history. He does have an elevated BMI at 31. He's got mild muscular tenderness over the tibant on the left greater than right, matching his symptoms. No bony tenderness on exam, normal tib-fib x-rays. So we proceed on the line. We want to rule out bone stress injury, just to be sure. We get that, and the MRI is normal. We see normal anatomy, and we go ahead and we're starting to think chronic exertional compartment syndrome. So we counsel him about this. We put him on the treadmill. Lo and behold, he's an overstride heel striker. We know that this pattern is associated with KEX. We start gait training him to a mid-foot strike, mid to forefoot, and he sees no improvement. So we counsel him, and we decide to do some intramuscular compartment pressure, or IMCP testing, or needle manometry, sometimes called. Here are his results. And as you can see, we do the pre-exercise, the 1-minute post, and the 5-minute post. We did all 4 compartments. Notice 1-minute post in the left anterior compartment, and I repeated the measurement and got the same number, or in the same ballpark, and so we confirmed it wasn't just a one-off error with the device. Okay, now pause for a minute. Let's consider the same patient with a little bit of a variation in his case. Now his pain is more posterior than anterior. We see no foot drop or foot slapping, no numbness and tingling that sets in with running. We do get mild muscular tenderness, but otherwise a very normal exam, normal tip-fib x-rays, normal MRI. So we do the IMCP testing, and it's pretty unimpressive. Let's say it's mildly elevated in the anterior compartments. The Pedowitz criteria are given below. I'll go more into that a little bit later. But so being a good sports medicine doc, you put your ultrasound in a popliteal fossa, and you notice that the popliteal artery is widely patent at rest, but when he forcefully plantar flexes his ankle and fires the gastroc and soleus, that popliteal artery compresses completely and all flow is obstructed. We have made a very good case for popliteal artery entrapment syndrome. There's more work to do. I'm going to go over KEX and PAES at this point. I'm going to try to keep it as simple as possible and the stuff that you need to know for your boards. But then, just like life, it gets complicated. I'm going to share some of the complicated side of things too. We'll start with simple. KEX, by definition, according to Pedowitz himself in 1990, said it's a condition in which exercise induces high pressure within a closed space bounded by bone and or fascia, resulting in decreased tissue perfusion and ischemic pain. Okay, a lot of people like that definition because it makes sense. It kind of makes anatomic sense. This is a process that we can grasp. It fits within our paradigm of how the leg is perfused. However, I'm going to show you later that there's problems with this. Before we go on, I want you to look at the compartments of the lower leg. We need to know the 4 compartments. We've got the anterior compartment in red. It's got the tibialis anterior, the long toe extensors. Blue compartment is the lateral compartment here in this image. We've got the peroneus longus and brevis in this compartment. In green, deep to the tibia and the interosseous membrane is that deep posterior compartment. You've got the posterior tibialis, and you've got your long toe flexors, the flexor hallucis and flexor digitorum longus in there. Then you've got the superficial posterior compartment in purple, which has got gastroc and soleus, plantaris, and neurovascular structures as well. Okay, Pedowitz criteria. You should know this because it may be on your boards. In my head, I just remember 15, 30, 20, and that's all I remember. That's enough for me. 15 at rest, 30 at 1-minute post, 20 at 5-minute post. Those are your thresholds. If you exceed those by this definition, that is considered positive for KEX. And so these can be applied traditionally to any of the compartments. However, they were described primarily for the anterior compartment. Treatment of chronic exertional compartment syndrome consists of beginning with basic initial care, activity modification. They may need to lose some weight, and biomechanics tells us that every time you hit the ground when you're running, that's 3 times the force of your body weight. So each pound you lose, I like to tell my patients, you're taking 3 pounds off of your leg when you run. And NSAIDs, physical therapy, certainly helpful as well. Gait retraining is an important and evidence-based component of care for KEX. We want to train them from a heel strike into a mid to forefoot strike, shorter cadence, quicker cadence, I should say. And this is often very effective if they're successful. But in my experience, success rates are lower than what is published because of the weight loss in my hands. In my experience, weight loss makes this hard. Botulinum toxin is another treatment that has been shown to be effective in small case series. We know that it can work often in for the short term. We do not know the long-term implications or how many injections is safe, and what are the side effects down the road. Fasciotomy is considered definitive treatment. Success rates vary widely between 25% success to 80 plus, even 90% success rates, depending on which study, and there's multiple studies to look at. Now, a little bit of gray area with these. KEX has some problems, and there's some work still to do. There are many confounding factors with IMCP testing. What position the legs are in, what exercise protocol did you use lidocaine and or ultrasound guidance, or both, or not? That is all a confounding factors, and there are more. Pedowitz criteria, as published, have very poor internal and external validity. The study, if you pull up that Pedowitz paper from 1990, it is a very poorly designed study. Kudos to Pedowitz for getting us a step forward, hopefully a step forward, but that study is poorly designed. It has poor validity and really shouldn't even be used. Negligible correlation between pain and pressure. On the right is a graph from Dr. Zimmerman, who's an expert in this area in the Netherlands, and he sees and treats a lot of this. He has published data on large numbers of his patients and found negligible correlation between increasing pain and increasing pressure, and there really is no correlation. And most importantly, in my mind, intramuscular compartment pressure does not predict the outcome of fasciotomy or other treatments. So what good is a diagnostic test if it doesn't help you get towards a treatment that's going to help? A very ambitious and talented team from the UK, Roscoe and company, developed a very rigorously controlled trial and developed some valid criteria that had a very high likelihood ratio. But the problem was the same group, the same patients, the same researchers, and they found that only 46% of these patients improved with a fasciotomy. So that's a problem. If these people who had been rigorously studied and very carefully diagnosed, only 46% improved with a good fasciotomy, there's a problem. There's more going on. Okay, we're sort of running low on time, so I'm going to try to move fairly quickly through popliteal artery entrapment. This is an anomaly, as defined by Hamid, anomaly resulting in symptomatic extrinsic compression of the popliteal artery by the surrounding structures, most frequently the medial head of the gastroc. This can be congenital or acquired. Here is a figure showing that four of the subtypes. The one on the left, figure A, is normal, and that's a normal anatomy. Type 5 is a venous entrapment. Type 6 is a functional entrapment with normal anatomy. So notice that there's different variations, ways that the popliteal artery can weave under, or different variations in how the medial head of the gastroc originates behind the knee. A lot of these can result in compression of the popliteal artery. Initial evaluation would be X-rays, dynamic ultrasound with Doppler, us being sports sonographers. That is within our purview. An MRI may often be needed to rule out BSI definitively. Either ourselves or a vascular surgeon should conduct exercise ABIs. And there's some studies that look at this. ABIs are helpful, in particular, when you look at a systolic blood pressure decrease of 14 millimeters of mercury after exercise in the tibial artery. That is indicative of popliteal artery entrapment syndrome. Normal subjects, after exercise, their blood pressure should actually increase by about an average of 8 millimeters of mercury. So that's a nice indicator that might lead you to a diagnosis. But definitively, what you'd want to get is CT or MR angiography. This must be done with and without forceful active ankle plantar flexion. CT angiography, in my experience and in a recent study, has been shown to be better than MR angiography because it's faster And it's easier for the patient to hold the plantar flex position for the entire duration of the study. With MRAs, you get a lot of false negatives because the patient simply can't hold their foot plantar flexed hard enough for long enough. Okay, so treatment. First of all, you need to recognize that these can involve acute ischemia and or thromboembolism distal to the entrapment site. So you need to keep that on your radar. This can be an urgent situation where you might need to call vascular surgery and they might need thrombectomy or thrombolysis. Stable patients, which in my experience is every patient with this condition that I've seen, would qualify or be probably recommended for an elective popliteal artery release. Timely diagnosis is key, especially for the congenital deformations, because those are known to result in post-stenotic aneurysms and dilatation. It can really damage the artery to the extent that if you don't get on it quick enough and release the artery, they may end up with a bypass. Functional popliteal artery entrapment seldom produces those aneurysms and ischemic complications. Now, just a few quick notes on where this stuff gets murky. PECs and PAES often overlap, and I don't have time to go through these studies, but patients with one often have radiographic findings of the other. And this has been shown in multiple studies, even recently from Dr. Finoff, Dr. Jelsing at Mayo, did this, and they used an MRI protocol where they could actually evaluate for edema in the compartments indicative of KEX, and they could evaluate for popliteal artery entrapment. So they found that over half, 51.6% of the people who had evidence on MR of anterior KEX also had radiological evidence of PAE. But we must remember that positive imaging does not mean that that finding is causing the person's pain. So it can be difficult to sort out, is it the popliteal artery entrapment or is it the compartment pressure, compartment syndrome that is causing the person's leg pain? This is a very interesting study by McGinley in CJSM in 2021. I recommend that you read it. In his study, he took 284 patients, retrospectively evaluated, and 260 of these 284, that's 91%, demonstrated MR findings consistent with KEX and CT angiogram findings consistent with functional venous outflow obstruction, leading to the conclusion, in his opinion, that KEX and PAES are not separate entities, but exist on a continuum of disease based on the severity of functional compression. I believe that he is correct. If we look at the muscle pump phenomenon in the lower leg, we know that the lower leg is unique because it is essentially our second heart. Up to 60% of the total energy for perfusing the gastroc and soleus comes from the contraction of those muscles itself. It's almost like another heart. The contraction expels blood and then it relaxes and creates a diastolic situation. So if you've got a muscle that's compressing that, you're essentially creating pump failure. And that's exactly what venous obstruction of popliteal vein obstruction would do. That's going to create that increased hydrostatic pressure and lead to transitation of proteins and fluids and create your distension and increased pressure in the compartments. I think that as a profession, we need to start moving and looking more at this entity, looking at dysfunction of the pump and looking at the overlap of KEX and PAES as a functional muscular entrapment of that vasculature. So today, what is a sports medicine doctor to do? So with PAE and KEX, I start with a thorough history and exam. Remember, these patients present very similarly, and they may have both. Start with x-rays, do gait retraining. If they are failing to get better, I will get an MRI, rule out bone stress injury. I will also put the ultrasound on their popliteal artery and evaluate it myself for functional entrapment. I will revisit gait retraining at that point, consider a trial of Botox, and I will make them aware of a fasciotomy and the risks and benefits associated with that. so that they can decide at what point they want to go that direction, if at all. If a surgeon requests that I perform an IMCP, I will do it, and I will use a 35 millimeters of mercury has been shown to be a little bit of a better cutoff at 1 minute or 5 minutes post-exercise. If IMCP is normal or borderline and ultrasound shows PAE, I will get a CT angiogram with and without ankle plantar flexion, and I'll refer to vascular surgery if positive. And if I find a patient that I feel has symptoms and findings consistent with both KEX and PAE, generally speaking, it behooves them to treat the KEX first. Do the fasciotomies first, see where they get. They may need popliteal artery release as well later, but I would treat the KEX first. Goals with treatment of any patient with exertional leg pain, I'm going to bring this back home now at this point, is that we're trying to get them back to play their sport safe and as soon as possible. So we want to avoid any adverse outcomes. We are going to, in particular, be mindful of displaced fractures. That is kind of the worst case scenario. We want to avoid prolonged or excessive pain and suffering. We don't want to delay diagnosis. We don't want to do any unnecessary tests. IMCP is painful. We also want to avoid having that patient transition back to a sedentary lifestyle due to fear avoidance or loss of fitness, loss of confidence. So it is a real deal, and we want to keep that athlete active and off the couch as much as possible. And in the context of all of this, we want to be able to provide our athlete with good, accurate guidance and set good expectations up front. Okay, take-home points, and I'm going to focus MTSS and BSI in this slide. Focus on a good H&P. It really matters. Get some x-rays and look at them. And that's important. Scan the patient. Don't be afraid to put the ultrasound down. Correlate it with your physical exam, and don't forget the broad differential, and don't put your blinders on. With MTSS, remember that this is often diffuse pain and tenderness, often a novice runner, and it's associated with excessive pronation or a narrow stance. With bone stress injury, remember that it is that a lack of bony tenderness has a 98% negative predictive value. When it's for BSI interdistal to the knee. If you suspect a low-risk injury, you can defer advanced imaging until about a 2-week follow-up and reassess at that. Anterior KEX is associated with an overstride heel strike gait. Often improves with gait training, Botox injection, or fasciotomy. These treatments often fail also. This can be difficult to treat. Remember that KEX and PAES are likely related. They often overlap, they coexist. Look at those popliteal vessels with ultrasound, and there's the image again on the right. Now, we're a little over time, and I apologize. We're going to do a little bit of CAQ review. So Andy, I'll go ahead and let you throw up the poll. Go ahead and take about 30, 45 seconds, read through this question, and we'll let you go ahead and respond. Okay, we've got 39 participants, and I'm not seeing any answers. I hope I didn't talk everyone to sleep.
We'll give it another 5 seconds here.
Okay. All right. So maybe there's oh, hey, the people are responding, so that's good. So the question is, which of the following is considered high risk due to its potential for non-union? And those 74% answered anterior cortex of the tibia, and they are correct. So good job. We're going to go on to question 2. I'll advance the slide. Let's see. Okay, here we go. CAQ review question 2. I'll let you read it. Popliteal artery entrapment syndrome most commonly involves extrinsic compression of the popliteal artery by which structure? We'll give you about 30 seconds. This should be a quickie. This is another one where you either know it or you don't know it. So, all right, Andy, let's go ahead and call it. And we see that, good job, 73% of you guys are correct. It is the medial head of the gastroc that is most frequently the culprit in compressing that popliteal artery. And we will go ahead and go on to the question number 3, and our last question. If this is a 20-year-old female, she presents to your clinic for evaluation of leg pain. She's got cramping. It sounds like KEX. You get IMCP testing, and you find that there's pressures as noted in the table. And we note of most prominently, I'm doing this for people who are just listening in their car 2, 3, 8 months from now. We see that there's a pressure of 48 millimeters of mercury in the left anterior compartment 1 minute post-exercise. Now the question is, which phase of the gait cycle is most likely to develop visible dysfunction in her gait as her symptoms worsen? And Andy, let's go ahead and look at the poll results.
We'll give it another
okay, so
5 more seconds for folks to chime in, since there was a little bit more on this one.
Yeah, you could choose early or terminal stance, or early or terminal swing. So what we're seeing is a pretty widespread in the results on people's polling. It is a more difficult question. The answer to this question is A, early stance. And the reason is because what you're going to see as this anterior compartment syndrome worsens and the pressure increases, you're going to see a nerve, you're going to see a foot drop. You're going to see that tibialis anterior start to drop out, and that deep peroneal nerve is going to become dysfunctional, and you'll get that slapping, that foot slapping, which you will notice in early stance, is that slapping foot gait. That's characteristic of anterior compartment syndrome. So, all right. So that, let me go back here. That concludes my presentation. Again, I'm sorry for going a little bit over. A lot to cover here, complex topics. And let's take some time for Q&A if you'd like.
Yeah, that was wonderful. Thank you so much, Dr. Nye. We do have a couple of questions coming in. So one of the questions is whether or not bone stimulators have been beneficial in the treatment of bone stress injuries.
Mm-hmm. Good question. So specifically to answer your question, are they of benefit? There is no good evidence to support that. There are a few very small studies. Most of the studies looking at bone stimulators look at acute fractures, and they can accelerate healing for acute fractures. But there's some newer types of bone stimulation that are coming out, and there's a lot of research going on in this area. So I would recommend that you stay tuned. This may be something that we start to see things being more beneficial in the future. But for the time being, these things are safe. They don't harm the patient other than the cost. And I really consider them very low risk. And so for some of the patients that have a very high risk, high grade injury, if it's a superficial bone, it's very hard to put a bone stimulator on a pelvic or a femoral neck bone stress injury. But things down and below the knee, yeah, you can use a bone stimulator, and I might consider that if I had like an anterior cortex BSI. So, or particularly the one that's taking a long time to heal. So, Julie, any thoughts to add on that?
No, I think that, yeah, overall low risk. So if you're stuck in a hard place where you need to try to get someone back sooner, you're just not seeing clinical or radiographic signs of healing, worth giving a shot.
Yeah.
One of the questions that came up was, can NSAIDs like COX-2 medications be used for bone stress injury pain management?
So, so to be pragmatic, yes, they can. I think that there's some drawbacks. And frankly, the main reason that I don't use NSAIDs or any pain medication in most cases of bone stress injury is because I want the athlete to know what their body is telling them, and I don't want them masking symptoms. There is concern that NSAIDs may impair the bone healing process. And so I prefer to avoid all types of NSAIDs. I prefer to use Tylenol, if anything. Maybe things like ice are better, and for analgesic effect. Maybe icy hot type, those kinds of topical analgesics. I really try to avoid anything that's systemic if I can. If they're having a lot of difficulty sleeping, that is the scenario where I really would consider something oral for pain. My first go-to would be acetaminophen, quite frankly. But I definitely would be open to the viewpoints of others. Julie, do you have thoughts, or even anyone on the call?
I personally try to hold any NSAIDs for as long as possible after any phase of acute injury. And we'll go to acetaminophen first or a topical analgesic. For superficial bone stress injuries or any type of superficial pain, I actually like ice cup massaging. So I'll have them fill a Dixie cup, freeze it, and then they can get some, um, better clearance of edema and that sort of thing with it.
Excellent. Yeah, I completely agree.
And then we have time for one more question. So one of the ones sent to me was, how frequently, when you're monitoring for bone stress injuries on radiographs, how frequently are you obtaining those radiographs, and what signs are you looking for to progress them to kind of the next phase of that progressive weight bearing?
Great question. I love that question. So about 2 weeks is the interval that I would use between these X-rays. Sooner than that, if closer than that, I really don't think you've given enough time to show any changes or any progression. Really, what you're trying to catch is the body's healing response that's catching up and starting to show some mineralization within the, either within the bone or that periosteal reaction. If we had more time, I could show you more X-rays. Sometimes the periosteal reaction can be quite extensive or involve a long portion of the bone, or it can be more focal, can be subtle. Sometimes with a bone that's like cancellous in nature, mostly cancellous or trabecular, like the calcaneus or the talus. These bones are not long bones, and most of the structure is cancellous or spongy bone in nature. And in these bones, what you're going to find is almost like a cloud, a puff of chalk that went over the internal, structure of the bone. And so you can see that really what that is, that's osteoid. That's an osteoid scar or callus that's forming. That is, when you see it on the X-ray, that's calcification. That's mineralization of an osteoid matrix scar within the cancellous portion of the bone. And what you would see on MRI in that case would probably be described as a fracture line by the radiologist. However, this is another topic, but I dispute. I do not think that the term fracture line, as used to describe the T2 hypointense, the dark T2 dark region within the marrow cavity of a bone, or the cancellous region of the bone, that do not think that should be called a fracture line. However, that is the current standard practice. I think future research will show that that is not a fracture line. That is a callus that is healing, and it's just a healing process that has progressed to that point in the context of an injury that was severe enough to require that degree of healing. But it's not a fracture line in the truest sense of that term, which is a broken bone.
Perfect. Well, those are all of the questions that we have. I'll offer it up to you again if you have any final thoughts or things that you want to just share with our viewers.
Yeah, no, this is a very interesting topic, and as you can tell, there's a lot to talk about. More, I encourage you to use your ultrasound and just clinical skills and judgment. It takes a lot of reps of seeing a lot of these to feel like, at least in my experience, to get really feel more comfortable working through some of the more challenging cases. It is complex, and they do overlap, and you can have patients with multiple things going on and multiple diagnoses, so it can be tricky to sort through. But please reach out to me. I'd love to discuss or kick around some ideas if you'd like.
Well, thank you so much. I'll throw out one just additional thing just to stay tuned for those articles to show kind of some of the relationship between iron deficiency anemia and non-anemia and bone stress injury and kind of all the stuff that you're going to publish in the future. So
Yeah,
thank
we
you
do
so
have
much
a
for your
lot of
time.
exciting data coming out of basic training. More to follow on that.
Thank you very much.
All right. Yeah, take care. We'll see everyone later.